Now, that's empirical prescribing. You'll notice in that I did not give any regimes because I cannot in any way infer our epidemiology in the UK to the epidemiology of Jordan. But if you can develop those principles and validate the scoring systems for your region, then suddenly you start to have a much more finessed approach to how we can choose to give appropriate but not excessively broad empirical antimicrobials. So let's focus then on ESBL because they're everywhere. And if you think about us here in the UK, we have somewhere between 10% and 25% of our entire population colonized with ESBLs. And in some settings, such as intensive care inpatients, renal inpatients, up to 50% of all of the Enterobacterales grow from those patients are ESBLs. So we have a huge ESBL problem in the UK. But if we're going to start to think about ESBL, then actually what we need to do is dive down into that umbrella term of ESBL and think about what components make that up, because they're not all the same. And it is very easy to say meropenem for an ESBL, very easy to say that. But actually, if you understand the molecular mechanisms that underlie it, then you can give more finesse therapy. In exactly the same way earlier, as we were talking about, if you understand the molecular mechanisms behind carbapenem resistance, you can adjust your novel antimicrobial regimes. So ESBLs typically, as you know, E. coli have TEMs, Klebsiellas have Shivs, and they can hyperproduce those. But actually, the other thing that confers beta-lactam resistant are the OXA family, and particularly the simple OXA1 family. So not OXA48, we're talking about OXA1. And we'll come back to why that is important in a moment. Then you have the ESBLs, and they can be derived from TEMs, derived from Shivs. That's fine. We can usually overcome those with varigreves of penicillin-derived therapy. But then you have the CTXM family. And we in the UK, I guess 2/3, pulling a number out of the air, 2/3 of our ESBLs are within the CTXM family. And finding a non-carbapenem approach to the CTXM family, tricky. Not impossible, but tricky. So let's dive down into then what our national UK guidelines are. Then we'll touch upon what the US ones are they were released 4 days ago. So I don't hold it against you if you haven't consumed the entirety of the IDSA ESBL guidelines in the last 4 days. We'll give you a headline review of those. Let's start, of course, first with the UK. So Peter Hawkey, a couple of years ago now, put together these and systematically shifted through a whole load of data. And if you look down at the bottom there, found 0 papers which allowed him to quantitatively decide upon empiric therapy for resistant organisms in the UK. So what he instead did was go to one tier weaker evidence to derive the UK resistant organism treatment guidelines and looked at qualitative papers which he could qualitatively synthesize. So I will put that caveat out there. But this is the working flow diagram. This is the meat of this 60-odd paged guideline that Peter Hawkey put out. And this flow diagram basically says, have you got a suspected gram-negative infection? Look at local policy. Are you suspecting there's a multi-resistant strain? Which again, Peter Hawkey doesn't stipulate which you should use, but again, I would advocate to you Tombrello and Johnson determining whether your patient has an ESBL for empiric therapy. If you score highly on Tombrello's or Johnson's scores, then don't prescribe a cephalosporin. Just don't do it. Don't prescribe a trimethoprim, and as we've talked about all morning, don't prescribe a quinolone unless your back's really against a wall. And then try and determine whether they have carbapenem resistance on the back of that. And you can again use PHE, ECDC, or Paul Tambayer's approach or our approach, whichever. As long as you have a scoring system that works in your setting, it doesn't really matter what scoring system is. So then I'm going to delete the CRE things because that's being talked about this afternoon. Okay, that's why that bit's just disappeared. What we're now going to talk about then is this ESBL section, and you'll see that we in the UK adopt a really dichotomous approach. If you have a non-urinary tract infection, then really you need carbapenem. If you have a urinary tract infection, then you could use carbapenem, or you could also use Comoxiclav or tazocin. And before you all shout Marino at me, we'll perhaps come back to why the Merino study is slightly less important for urinary tract infections in a second. But what you'll see down here at the bottom is our consistent use in the UK of fosfomycin. It does work, but also pivmecillinam. So if we think about these other penicillins, now, first of all, I just wanted to draw your eye down the middle three columns there, the TEM ESBLs, the SHIV ESBLs, and the CTXM ESBLs, which are the majority of everything. And you'll see that clavulanate and tazobactam work against all three of these, but actually many of the actual beta-lactams are labile, and by that I mean piperacillin. So if you combine tazobactam with piperacillin, as we all use, azocin or tazocin or whatever your brand name is, then you are combining a useful inhibitor with the labile penicillin. But if we switch over and instead use something like aztreonam, or more importantly here to us, mesillinam, you can see how mesillinam in particular is moderately stable to all these beta-lactamases. So therefore, if we start to ingratiate mesillinam with some of these inhibitors, then actually you can overcome a lot of the ESBL mechanisms. Now, so that's a UK approach. So carbapenem heavy for non-urinary tract ESBLs, and then urinary tract ESBLs, fosfomycin, temacillin, and now these are Prof. Tamer's IDSA guidelines that were released just at the beginning of last week, 4 or 5 days ago. And as is the want of many IDSA guidelines nowadays, they are cast in a question and answer response, which suits me fine because I have a simple brain. So they talk about CREs, but the bit that we're focusing on here is the IDSA guidelines for ESBL. We have 5 main questions. So question 1 is, what are your preferred antibiotics for treatment of ESBL simple UTIs? And here, whereas we in the UK down a fosfomycin and mesillinam heavy approach, the Americans are going down a nitrofurantoin and cotrimoxazole heavy approach. We in the UK recognise that nitrofurantoin works. We would use it in uncomplicated cystitis, but of course it is not approved for anything that has a febrile component to it. So we are slightly more anxious about that. We do in the UK recognise use of cotrimoxazole where susceptible for ESBLs, but we find a considerable proportion, so over half of our ESBLs are also resistant to cotrimoxazole. So we have a different approach to the IDSA, and I guess it would be interesting perhaps in the discussion afterwards to see if you determine cotrimoxazole susceptibility in your ESBLs in the MENA region, because that might dictate whether you adopt more of an IDSA approach or not. Question 2 was, if you have a significant urinary tract infection, so a pilot ESBL, what can you use? So the Americans are going, again, heavy down a carbapenem route, that's fine, so do we. They also leverage into quinolones, which we do not at all in the UK, for many reasons, as we discussed earlier. And again, they are happy to use cetrin for a significant urinary tract ESBL infection, but as I said, we don't do that in the UK. And then what about an ESBL infection outside of the urinary tract? So remembering that our UK approach is carbapenem heavy, and the US approach is exactly in line with that. So for a non-urinary tract ESBL infection, both we and they concord that carbapenems are the drug of the day. And then the last 2 questions kind of hark back to this Merino study, right? Or certainly question 4 does. So question 4 was, what happens, or can you use tazocin? So piperacillin and tazobactam for an ESBL. And the Merino study obviously suggested we avoid using piperacillin and tazobactam for ESBLs because it only had just over half success rate, I mean just under half failure rate. But the problem I have with that is that I could have got away with using tazocin in about half the time, meaning that I can avoid my carbapenems, meaning that I can avoid my driver towards carbapenem resistance from using carbapenem. Now, I would not purposefully start tazocin for an ESBL infection. I'm not that foolhardy, but I like the phrasing that the IDSA have come out with last week, which is to say, if you are already on tazocin and you are getting better, but you find it's an ESBL, why switch? Why? Just carry on your tazocin. And I think that's a worthy approach, and I'm probably going to push that hard in my UK setting. I will take that away from the Americans. And question number 5 is very similar, but it uses cefepime. So not many centres in the UK use cefepime. My centre is one of them. And we had not hitherto used it for ESBLs, only for AMP-Cs. But again, here they're saying, if you have somebody on cefepime and then you find that it's an ESBL, but they're already getting better, don't just change it for the sake of it. Just push on with your cefepime therapy. So I'm probably going to take that away from the IDSA guidelines this week, and hopefully save myself a few DDDs of meropenem in doing so. So therefore, when we are putting all of this together, we are deriving our empiric prescribing policies and disseminating those through our organizations. And when we are developing our treatment strategies in our policies and educating our clinicians for treatment of ESBLs, we've got to be cognizant of all of the actors involved. And as you can see, it's a multi-professional approach. And what I quite like about working where I work are the external bodies. And in particular, I mean by that, my biologists, in particular, my access to specialist society support. And we have some very active infection societies in the UK, not quite as active as the IDSA, but are really good. And I know that you're developing the Regional Centre for Disease Prevention and Control. Apologies if I get the lettering order wrong there, Mania, but I think there's a real force for good development. Critical mass of expertise now. But then that's kind of the meta level stuff you can do. But what I would advocate, harking back to my earlier lecture, is that we need to bring laboratory results forward to influence empiric therapy and to influence choice of agent in ESBL therapy. And really, if we've got the person power, and I don't have the person power, I'm deplete in infection specialists. We need to be bringing our consults earlier in the patient journey into ED. And I long for the day that I can stop doing all my paperwork and go and do that again. But I'm not there yet. Right. So we've gone through the risk factors for colonization and infection with MDR organisms. We've explored the patient pathway, things that we need to be thinking about when we're deriving our empiric prescribing policies. And we've reviewed both the UK and now the 4-day-old IDSA guidelines for ESBL therapy. As always, I am a tiny little cog in a massive system, and I am forever grateful to these people and everyone else. Thank you for listening.